Hello and welcome to Wellness Wednesday. I am Sally Duplantier. I'm the founder of Zing, and I'm also the host of the Wellness Wednesday program. This is our 97th program, I want to say. And today's topic is one that's near and dear to my heart when it's more than a headache. As I've told some of you, I have suffered from migraine headaches for the last 62 years. So I looked long and hard to get a really wonderful specialist on the topic of headache. I am delighted to welcome Dr. Olivia Begasse De Dhaem, who is an MD and a headache specialist. Welcome, Dr. Olivia.
Thank you, and thank you so much for having me. It's an honor and pleasure to be here today.
We are delighted. So, a quick thank you to our promoting partners, all these different organizations who help get the word out about Wellness Wednesday. And also a thank you to our community supporters. As I say every time, these programs are free to anybody who wants to attend, but they're not exactly free. There's a cost to producing them. So your contributions help cover the cost and make them available to all. I deeply appreciate that. Now, I want to introduce Dr. Olivia. She is a board-certified neurologist and specialist in headache medicine. She also serves as the medical director and founder of the Institute for Headache and Brain Health. She's an assistant professor of neurology at the University of Connecticut, and she's co-chair of this amazing organization I'd never heard of, the American Headache Society Advocacy Committee and Global Patient Advocacy Coalition for Headache. And she's dedicated to not only cutting edge research, but also patient-centered care. And part of the reason I selected Dr. Olivia is because she's as compassionate as she is knowledgeable. So thank you again. Now, here's how today's discussion is going to go. This is an interview, but there's a lot of information here. That's part of why we're recording it, because there's a lot you may want to go back and listen to. We're going to talk a little bit about the basics of what are headaches, how do they change with aging, and then we're going to talk more at the end about migraine and chronic headaches. So I think there's something for everyone, whether you do or do not experience headaches. We're going to make sure that we give you some new content and some new information. If you have questions as we go, type them into the Q&A. You'll see 3 dots and there's a Q&A section underneath there. Note that Dr. Olivia can address educational questions, but she can't diagnose you over this webinar. And I am going to send you later this afternoon the recording, a transcript of our discussion. You'll get the slides. And Dr. Olivia and I have made an amazing 5-page handout for you. So lots of stuff. Okay, so let's get started. So I hear these terms primary headache, secondary headache. What's the difference between those?
Yeah, primary headaches, the headache is part of the disease itself. The headache is not caused by another condition. So common primary headaches that people tend to hear about are migraine or tension type headache. Secondary headaches are due to another condition. So for example, if you have a headache because you have the flu, the headache is due to the flu, it's a secondary headache. Sometimes it can get tricky because some secondary headaches have symptoms that are very similar to primary headache and they can mimic primary headache. For example, a lot of people who have concussion, then they get headaches that look like migraine. And then the opposite is true too. Sometimes some primary headache can mimic secondary headache, like sometimes sinus issues are actually sometimes symptoms that are attributed to sinus issues, it's actually migraine, or sometimes people think they have an issue with the teeth and it's actually cluster, another type of primary headache disorder. In general, when a headache starts with the start of another condition and gets better when that other condition gets better, we say it's a secondary headache.
And so this is it's a great distinction. As you and I were talking, you introduced me to something called Snoop, because you said that, geez, sometimes when secondary headaches start to present, it could be a warning sign of something else, especially for older adults. So let's talk about this.
Yeah, Snoop is a mnemonic of what we call red flags. So red flags are signs or symptoms that would make a secondary cause of the headache more likely. So that warrants, further evaluation and maybe workup. Some of these features is like systemic changes, the like fever, weight loss that you don't mean to, unintentional weight loss, neurologic symptoms like weakness, speech issues, sudden onset, we mean reaching peak maximal intensity of the pain within 1 minute, new worsening change in pre-existing headache after 60, a headache that is worse laying down, waking you up from sleep.
And what is this one, the positional change,
Yeah.
precipitators, and papilledema?
Yeah, so position change, we most often it's like the issue worse headache laying down, waking you up from sleep. And then some people too actually have different types of headache. They cannot even stand up. So the position change being standing up versus lying down. And then papilledema, that's part of the exam. Nobody could really test themselves for papilledema, but that's what we look for when we look inside the eye with the ophthalmoscope. We're not trying to look for any vision testing. We're looking at that nerve that is an indicator of the pressure inside the skull.
Okay. So my takeaway from this, and you and I, we've chatted about this before, is that, yeah, like any of these kinds of changes could be a warning sign of something else, and to take it and to take it seriously. I think that's one of my big takeaways from this discussion. So you mentioned earlier, you said primary headaches. You mentioned migraine and tension headaches. Like, like I've had migraine for 62 years. I always think everything is a migraine. But is it possible to have both migraine and tension headaches?
Yes, it's very common for people to have multiple types of headache, and once you have one type of headache, you're more likely to have another type. That being said, migraine, when you have migraine, not all migraine attacks are the same, even within the same person. People can have milder headache days and full-blown migraine days, and this is still considered part of the migraine. Some people can have different types of primary headache disorders, such as migraine and cluster, or migraine and trigeminal neuralgia. Mentioning trigeminal neuralgia here because it's one of the headache disorder that is most commonly seen in middle age or older adults, and the specific type of facial pain that is kind of electric like shock or shooting stabbing pain, a specific distribution of the face for seconds up to 2 minutes at a time, that may be triggered by things that would usually not trigger pain, like chewing, brushing your teeth. It's important though to not everything is migraine. Migraine doesn't explain everything, so it's important to not brush off things on migraine. If people have a long history of migraine and then at 70 years old they have a complete change in headaches and new symptoms, we cannot assume it's migraine, and we have to take a step back
Yeah,
and make sure we're not missing anything
yeah,
else.
that's good advice. So you also mentioned cluster headaches. I'm curious, what are cluster headaches? How are they different maybe from migraine or tension headaches?
Yeah. Cluster headaches, it's another type of primary headache disorder. So to be the worst pain known to man, so extremely painful, usually lasting between 15 minutes to 3 hours, but people have different attacks. On one side, usually, in the around the phaser eye area. And often the pain is associated with what we call autonomic symptoms. So red eye, tearing, droopy eyelid, nasal congestion or runny nose, sense of restlessness.
Yeah. Okay. So not everything is just migraine or tension, but likewise you could have multiple types of headaches. Let's go to this term. I hear this a lot. Medication overuse, especially for people with chronic headache. You're like, oh my gosh, don't take too much medicine. You're going to get a medication overuse headache. What is that exactly?
Yeah, people have tried to suggest the term medication adaptation headache to try to not put the blame on patients, but in a diagnostic criteria, it's still called medication overuse headache. And it refers to the idea that if you take as needed acute medication for headache quite frequently, that leads to central sensitization. The brain gets more sensitive to pain, gets used to taking those medication, and the idea that this makes the whole thing worse. Um, Common culprits tend to be medications that are usually not recommended for headaches in the first place, such as opioids and barbiturates. There may be an issue with tolerance for these medications too. But I think it's important to differentiate medication overuse headache from untreated migraine, because undertreated migraine is actually a big risk factor for worsening of the migraine. And people don't take medications for fun. People will take as needed medication frequently because they have frequent severe attacks and they want to function. So to me, I think frequent use of medication, instead of saying like bad, don't do it, I think it's seeking care from a healthcare professional to see, like, do we add or start preventive treatment, optimize acute treatment, and give a better treatment plan so people don't have to take as needed medication too often.
Yeah. And my takeaway from this one is, first of all, they always used to treat migraine with opioids or chronic headache with opioids. Not doing that anymore makes us more sensitive to pain, not less. Can you weigh in on triptans? And this is a little bit of an inside question for people with migraine. I realize not everybody here has migraine, but triptans are typically used by migraine patients for acute headaches. There's a tendency, though, to only take like one or two, and then it's like we can't take any more because of medication overuse. Do you have a perspective on that?
Yeah, if we look, we don't have great data, to support medication overuse either. But if we look at the guidelines, and that's basically made, those guidelines were made based on consensus. They recommend no more than 10 days per month on triptans and combination analgesics, like Excedrin and stuff, and no more than 15 days per month on regular analgesics like NSAIDs. But, keeping perspective, I think people do what they can. And if you feel like you are reaching that point, is talking with a healthcare professional to see how we can optimize. It breaks my heart when people are in bed suffering with nothing because, oh my God, I cannot take a
Yeah,
full triptan this week. Like,
yeah,
it's all
yeah.
a question of the risk benefit.
And I'm nodding, and I think anybody who's experienced migraines has been in that position. So now let's go back and I want to talk a little more generally about how headaches change as we get older. So let's just start in general, how they might change, and then we'll get into migraine in older adults.
Yeah. Um, Migraine and other headache disorder often change throughout someone's life. For example, migraine is a disorder of brain sensitivity, and there are worse time, better times, different symptoms over someone's lifespan. In general, those prevalence, intensity, the frequency of migraine attacks decline with age in general. Unfortunately, for those who continue to have migraine attacks, especially in women, later in life, they tend to have more frequent attacks.
Yeah.
So,
Well, and we'll talk about how they change in a moment. How about just general headaches, like tension headaches? Do those increase, decrease as we get older?
I think it's different because we don't see the same thing, right? We may see more plain bread and butter tension type headaches like earlier in life, like early adulthood, middle age, and then more headaches related to neck issues later in life. So it's just different issues at different stages of life. Yeah.
And we will get into those neck issues. Okay, so let's take a look at this. I found this fascinating. And again, not everyone in our audience has migraine, but let's talk about some of the typical symptoms and then how it might change as older adults. Can you walk us through this table?
Yeah, and yeah, that's from a paper that, yeah, it's interesting to actually see in general, right, how it changes. So usually the worsening of the pain from regular activity is less prominent. The unilateral one-sided character becomes less prominent with time. There tends to be less sensitivity to light and sound over time. Aura, we forgot to, well, I didn't mention
Can
it
I
with
can I
aura.
define aura
Uh,
for people? I had my first aura at 10 years old. I thought I was dying. So what aura is for people who haven't experienced it, it's these like wavy lines that it may start as a little bright light, and then pretty soon you actually have no vision or peripheral vision. It can last a few minutes, it can last an hour. It's scary until you know what it is. Yes. Yes.
exactly.
More
Yes,
aura as we age, yes.
the symptoms are progressive, and yeah, and sometimes for people with the few people with new onset migraine later in life, sometimes it presents with aura. And yeah, as I mentioned, unfortunately they tend to be more frequent for
Yeah.
those with
Yeah.
migraine later.
But I think for those of us who have migraine as older adults, this is kind of comforting to know that we're not alone and that it's like, how come these are getting worse? Yeah, there is a reason. One thing that's not on here, it probably wasn't in the paper. Have you noticed with your older adults, do they complain more of when they get migraine of chronic fatigue that accompanies that? Just curious if you,
Well, it's hard for my patient population because I think when they reach me, it means that things have been bad. So fatigue is a very common complaint with headaches. Actually, a lot of different types of headaches that I see, whether they're 20 years old or 80 years old. But fatigue is definitely a very common complaint. And some people actually, the fatigue is a biggest symptoms of the postdrome, like after the headache phase, left with days of fatigue afterwards.
yes, yes, I know this one. I do. Okay. So now, kind of in general, part of what we want to talk about is like know the warning signs. So when does a headache in an older adult signify that maybe something more serious is happening?
Yeah, and that's not to freak anyone out, but I think it's important we discuss. And I think like worse things first, like calling 911 if you have an acute onset headache reaching peak maximal intensity within 1 minute, like that needs to be checked out really quickly. If you have a headache, new acute neurological symptoms like loss in vision, issues, your eyes are not moving, your pupil are black in your eyes blown, your face is not symmetric, weakness, speech issues, new issues with balance, vertigo. And that's because we don't want to miss a stroke, whether it's a clot or a brain bleed. Coming with that too, and it's not directly related to headache, but I think it's nice for people if you're on anticoagulant because sometimes later in life more people are on blood thinners, anticoagulant. to tell people around you you are on it. So if something were to happen, this information can be relayed to healthcare professionals.
So let me make sure I understood that last part. If you're on anticoagulants, blood thinners, you should let other people around you know about that or wear a bracelet or something like that. Is that correct?
Yeah, because if one of these things we just discussed happen, one of the first questions that's going to be asked is, are they on any anticoagulants? And the person whom it's happening may not be able to answer. So
Yeah.
that's helpful information to know and to share with loved ones. Yeah.
Yeah. And I think, as you and I were talking before, getting ready for this presentation, even if you have migraine, if you have migraine and you say, oh my gosh, it's just a migraine, no, these are warning signs that you need to pay attention to. Yeah, because it's
Yeah.
different. Yeah.
And it's important to know so you can advocate for yourself, because some people are like, oh, you have a history of migraine. Oh, yeah, that's just your migraine. Like, absolutely not. Like, this is very different from my migraine. Like, it's important to feel empowered to
Yeah.
voice it. It's very
Yeah.
different.
And Dr. Olivia, I will say that one of my takeaways from working with you now, just on this presentation, is just that, like, don't blame myself. Like, stop blaming myself because I have migraine, or what did you do? What caused it? That type of thing. It's a disease.
Yeah.
So, okay, so you mentioned in the last sign, a headache could actually be a sign of stroke. And how do we know the difference? So for people with migraine, they get aura, they get these little wavy lines. We're used to them. But you said that some stroke warning signs can look like migraine aura. So let's talk about how to distinguish them. And I love this chart you put together. So let's talk about this, the difference between migraine aura and something called a transient ischemic attack.
Yeah, and it's important because sometimes it's hard to differentiate for a patient and for healthcare professionals, right? And in case of DOP, it's good to get checked out. But transient ischemic attack, TIS, people call it mini stroke, but there's nothing mini about it. Saying, as I said, it's mini because you have these acute symptoms and then they get better. But having a TIA puts you at high risk of full-blown stroke. So that's why we don't want to miss this, and that's why you need to get evaluated, and that's why we try to differentiate. So usually when that happens, the headache comes with the symptoms. With aura, you get progressive symptoms that tend to resolve, at least most of them, and then you get the headache.
Right, so the aura starts first. And what you're saying for TIA is that the aura is happening at the same time as the headache. Is that correct? Did I get
Yeah,
that right?
for TIA, it's not an aura, but yes,
The
exactly.
headache. I
At
got it.
the same
Yes,
time.
got it. Yeah.
Yeah. And then, so TIA, like stroke, it's negative. You don't get enough blood. So the vision gets black. You lose your vision. You don't feel your body. You cannot move your body. If it's migraine aura, you usually have what we call positive, like you were describing, right? You have scintillating spots in your vision. You can have tingling. That's what we call positive. Not that it feels positive, but it's you actually have new things, new signs. For TIA, it tends to be sudden, abrupt, and as you beautifully described, for aura, you have a gradual progression of the symptoms.
Yeah. Yeah. Okay, so this makes sense. And again, it's like know the warning signs and take this TIA very seriously. It's not like you said, it's not just a mini stroke. It's going to put you at greater risk for stroke. Okay, so as you and I were talking, you said, oh my gosh, Sally, there's some other headaches we shouldn't miss in older adults. So we're not trying to scare anyone, but we're trying to
Yeah.
help people take this seriously. Yeah.
Yeah, order makes sense, but I promise you there's more hopeful things, but it's good for people to know. Yeah. So One thing to not miss is brain tumor, obviously more rare, but that's why oftentimes people get imaging to make sure that's
Mhm.
not being missed. There's another condition not to be missed, giant cell arteritis, that has some inflammation of specific blood vessels. Typically, this very typical clinical picture of this, most patients, the body does not follow the textbook. There's a pretty easy screen for it, testing blood work for inflammatory markers. So because for most people that really doesn't follow the textbook picture, I think if new or different headache above 50, I think it's just reasonable to test with blood markers for inflammatory markers to make sure it's not getting missed.
And I just have to share on a personal note. I was tested for both recently. I'm fine. It's just migraine, but it's exactly what you described. The headaches were so much worse. And my neurologist said, hey, we need to test for both of these. Yeah, so this is an MRI. This is a blood test. It was simple. And yeah, I'm fine. Okay, so let's talk about what other conditions are commonly associated with headaches in older adults. And I think we have a good slide for this.
We talked about all the scary things, but common things are common. One of the basic one, unfortunately, a lot of people are living their life with high blood pressure, headache. When blood pressure is controlled, usually the headache gets better. Another big issue is in clinical practice with all the patients is polypharmacy, on so many medications to the point we would not even know what interacts with what anymore, and often cleaning up, trying to prioritize and making things simpler actually can help with headache. Another big thing is neck, and neck issues too can lead to headaches.
Yeah, and let's talk about again, and people will have the slides, so you'll be able to see the whole list. But let's talk about neck more, a little bit more, because I think people with frequent headaches have frequently wondered, oh my gosh, is it something with my neck? So let's talk about this graphic here.
Yeah, and this graphic show, knots in different muscles of the neck, and it show really like that if you can have some tense point trigger points like muscle knot in different areas of the muscles of the neck, it actually creates pain that is headache, and it can even be for that one the sternocleidomastoid. It can be in the front. Commonly we see this. So that's showing neck muscle tension showing up as headache. There's different ways that this can happen. They can be tension of the neck muscles plus or minus also cervical spine like disease and some irritation of the nerve from bony changes, and these tiny nerves in the back of your head coming from the top of your neck. They go to the back of your head, but they can also connect with a trigeminal nerve in the front and have referred pain, but they also can mostly cause pain in the back of your head. So we have to keep the neck in mind too.
So the neck for anyone with headaches of any kind, the neck is really key. And it sounds like some of it could be just tightness, maybe from bad posture, or it could be actual changes in the bone in the cervical structure that come with age. So then what do we do? So do you have a professional opinion about, let's say, massage or chiropractor if we're having problems with our neck?
Yeah, and it also depends, on what these different issues. People can have neck muscle tension, or they can have different bony changes in the neck. So it also depends. But oftentimes, neck physical therapy for people, for physical therapists who are trained in neck, tends to be a good first step to do the evaluation and teach people how to strengthen and also loosen the neck muscles. But I think part of the key here is to go see someone who is specialized in neck and never let you know your body best. This is a very fine balance. So not letting anyone do something that doesn't feel right to you
Yeah,
at the end of the
yeah.
day.
I would never have thought of a neck physical therapist, and yet I'm a big fan of physical therapy, so it makes sense. So you could simply get a referral to a neck physical therapist from your physician. Yeah. Okay. So next, let's talk about triggers. Anyone with migraine knows that they have triggers. And I think we feel guilty because we should know our triggers better, but people with migraine find that, they might be able to do, I don't know, eat chocolate one day, and then the next day, or it seems like the next day, it causes a migraine. Or it seems like they've avoided all of their triggers, and then a meteor descends from outer space. That's always my favorite, when it doesn't even seem to be a cause. So why do these migraine attacks seem to come from nowhere?
Yeah, we have to put things into perspective too. In migraine, people keep talking about trigger, and patients should observe the trigger so much and avoid the trigger. First of all, it's really hard to avoid triggers. Like a lot of people is weather changes. Like you cannot avoid weather changes.
Oh my gosh, there's a storm coming. I mean, that's true. You're right. We can't avoid
Like,
it.
yeah,
Yes.
what are you going to do about it? So telling people to avoid the triggers of stress, let's live a life. I mean, we can manage a stress reaction, but stress will be there. So migraine is a chronic neurological disease, like with episodic attack, hopefully for most people, um, very similar to epilepsy. And I feel like in epilepsy, there's not so much focus like, oh, you had a seizure, what did you do, what did you eat? And the attacks are part of the disease. The migraine attacks are part of the disease. The disease is creating these attacks. Then there's the idea of trigger, worsening factors. So now migraine is a disorder of brain sensitivity. Your brain is more sensitive to things. So sometimes too, it's hard to pinpoint because it's not one trigger or one thing that makes things worse. Probably during this time, there were already a propensity to a migraine attack, and then there were weather changes, hormone changes, flashing lights, like noise outside, so you didn't get a good night of sleep, and this all added up, but it's hard to pinpoint one thing because it's a combination of things. But also going back to the idea of triggers, now with the understanding of migraine attacks, we also think that a lot of things that were considered triggers are actually not triggers, but they may be the first sign of the first phase of the migraine attack, what we call the prodrome. So it may not be that chocolate triggers migraine. It may be that you were craving chocolate because of the initial onset of the migraine attack.
I will confess that I crave macaroni and cheese. I do. I do. And
Yeah.
and it really does seem to be correlated with migraine. So I love what you said too about not blaming ourselves. I think that again is one of my big takeaways from talking to you. Not letting other people say, "Why did you do that?" or "Why don't you know what it is?"
Oh,
Okay.
one of my, not in your question, but it comes a lot right now in clinic. Why did you go on vacation? I'm like, what? Oh, but you went there, you went to Disney. I'm like, oh yeah, because it's forbidden for people with headache disorders. Like, no, we have to live a life and we have to optimize the management so it gets
Yeah.
better, but we cannot avoid, otherwise we would avoid so much stuff in life.
I would agree. And like you said, it's usually not one thing, it's cumulative. It's like a bucket. We keep throwing stuff in the bucket, and at some point, the bucket overflows.
Exactly.
Okay, so this one is a concern for a lot of older adults. And I know the literature is somewhat mixed, but let's talk about this. What is the general consensus about if migraine increases the risk of dementia?
Yeah, and the general consensus is that right now we have really no good evidence to be worried about a link between migraine and dementia. Yes, there is a few studies that suggest that there may be a link, mostly in women and people with migraine with aura or possibly chronic migraine, but most longitudinal studies that have been really well done do not support a strong and consistent association between migraine and dementia. Now thinking about it, answering this question, also some people have concern about the white matter changes we see on MRI sometimes with migraine. The migraine related ones are different from the vascular ones, and the migraine white matter changes are also not thought to be associated with dementia risk either.
Okay. So that's pretty, I mean, that's pretty good news. That's like one less thing to worry about. Yeah.
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 The problem looking at studies is that some studies make this bold statement, and when you look at the age of the participant, like the median age is 40, because we know that migraine, early in life, migraine itself is associated with cognitive changes. But then that seems to normalize later in life. And these early studies that don't look at dementia, they look at cognitive changes that you can see with migraine. So they're not looking at the right thing. But if you look at the abstract of these studies, they may tell you it's associated with dementia.
Yeah. And to Dr. Olivia's credit, we looked at a lot of studies. If anybody wants some of those studies, we have them. We have about 14 studies we could send people if they're interested. Okay, so now, we're at the end, we're going to talk about lifestyle. But I think it's worth talking about just some of the newest treatment. And in our interest of time, we're going to talk about something called CGRP inhibitors. And then we're also going to talk about neuromodulation devices. So let's talk about CGRP inhibitors.
Yeah, and you mentioned back in the days people were using a lot of opioids and barbiturates because that's what they were. And now with the increasing understanding of migraine, we've seen new treatment, and with new treatment, new hope. Like in the early 90s, triptans, where the arrival of triptans changed everything, and that's thanks to our understanding of one of the first steps of the migraine attack and the basis of our brain. Triptans regulate the serotonin input that mediate pain, but that's one of the first steps of a migraine attack. Once it passes that step, you have different changes mostly mediated by CGRP, calcitonin generated peptide. And that discovery from increased understanding of migraine led to new treatment. And there's two main types of CGRP blocking treatment. There's GPANs, which are oral or nasal spray, or the injectable, which are self-injectable or IV medications.
Yes. And so what happens, tell us a little bit more. What is CGRP? Is it a neuropeptide or neurotransmitter?
Yeah,
What
so
is it exactly?
it's actually in a lot of places in your body, but in terms of migraine, so when you get a migraine attack, that mediate what we call neuroinflammation and the sensitization of the nerves that lead to a head pain in your head. Yeah, so blocking that basically reverse this process.
Yeah. So these are new. They've been out since 2018. As you pointed out, I originally had a slide. I said, "Oh, there's six." You said, "No, there's seven." I will just say, as somebody who's had migraine, who has migraine, I've tried many, and many didn't work. I finally tried one that is helping me. It's very individualized. So if this is a route you decide to pursue with your neurologist, keep at it because I have really found something that has worked and I was ready to give up. So there there's a lot of options. But these I haven't tried. So tell us about neuromodulation devices. And all of this, by the way, is in your handout. We have a lot of detail about this. So we'll just talk at a high level.
Yeah, that could be a,
It could
a
be
whole
tough.
lecture. But knowing that it's there, because not everybody does well with medications. Migraine itself, some people with migraine, the body is very sensitive to medications, and then there may be other disease issues that limit the medication. Some people prefer non-medication approaches, so there are different devices that help tune down the response to pain in different ways. Like some target the nerve in the forehead, some target the vagus nerve in the neck, some target the back of the head, some actually target both the front and the back. And then there is also an armband. And some can be used acute or as a preventive tool on different modes, but that's another option that can be used by itself or in combination with medications.
I was just amazed as we started looking at the research how many different options there were. Do you have patients who use these regularly? I'm just curious.
Yes, yes. And I see a lot of pregnant patients too. So pregnancy is a big one. And then also later in life, when people are on so many medications, including some that literally interact with so many others, unfortunately, then options can be limited. So that's nice to have different non-pharmacological options.
Yeah. Okay. So we've talked a lot about, what to do. We've talked about a lot of different options. And yet I am sure are people still in this audience who have chronic, unrelenting headaches. They may or may not be migraine. I mean, and that's what do you recommend? And I'm going to share this high level slide, but I will tell you that Dr. Olivia has 3 pages of content related to this. So please read your handout. But let's talk kind of high level about why is this holistic approach so important?
That's generous of you. I threw a bunch of things at you and you made it in a beautiful handout. So
We've got,
I
we've got
cannot
pages.
take the credit for the handout. I'll give you the credit of the handout. But yeah, we like a multidisciplinary, multifactorial approach. We know there's medications out there. We talk about neuromodulation. Everything is together. So lifestyle changes. And one of the key of lifestyle changes, though, is to do changes that will be sustainable. And if you can enroll a friend or family member, that's even better. It's easier to do things as a group, but regular meals is a big one, not skipping breakfast. Diet, it's nice to have a healthy, colorful diet, limiting processed food, making sure based on what you can tolerate, you keep moving or start slow, go slow if you have not been able to mobilize in any way. Then migraine and a lot of headache disorders are terribly isolating. So having your allies, building your community, even if it's a few trusted people that don't drain you because they won't offer information you don't want to hear, like having this, it can be small, but this group of people so you feel less lonely dealing with the severe diseases. In terms of biobehavioral approaches, actually different biobehavioral approaches, and they have good evidence. For migraine, I think there should also be a low threshold. To see a pain psychologist is extremely mentally, emotionally hard to live with chronic pain, waking up every day, dealing with this again and again. And chronic pain, depression, anxiety are mediated by the same areas of the brain, so they can feed on each other. Pain affects self-esteem, self-blame, self-guilt, loneliness. So enrolling different healthcare professionals if you
And
can.
you mentioned a pain psychologist. I'd never heard of that before. A
Yeah,
pain psychologist. Hmm.
and that It's even sometimes deeper than that. There are psychologists that are trained in headaches, like even more
Wow.
specific than chronic pain. Yeah, they are wonderful and they are, I would say. And then, yeah, so we have evidence for cognitive behavioral therapy, biofeedback. Um, I think, yeah. And in terms of medication, I think that's important to be mindful of. There's higher risk of side effects with age. There's more risk of drug-drug interaction as people get placed on so many medication. So I think it's important to bring all of your medications to your clinic visits, as annoying as it can be, but to make sure we limit polypharmacy as much as possible, and nothing that would make things worse is prescribed. And then knowing that no matter your age, you deserve appropriate treatment. The myth of the, like, I've heard people who were denied triptans because they were 66 and you cannot get triptans after 65. That's absolutely not true. There's no guidelines that prohibit people to not have triptans after 65. Really, the cardiovascular contraindications to triptans. So if that's the case, that's a different discussion.
So this has been fascinating. We have covered a lot. I said earlier when we were talking, I said, I wonder if people will have questions. We have like 16 questions in the
Oh,
Q&A.
wow.
So we have about 15 minutes to talk about that. And I'm going to try to translate this. So I'm not quite sure I understand Mary's question. Mary, you might need to reword it. It just says, with stress, had migraine, headache, and eye. So I'm not sure what the question is there. Is that something, Dr. Olivia, that you are familiar with?
Not, I mean, I'm not sure I understand
No,
the.
Mary, what I'm going to ask is just to actually retype that question so we can answer it because I'm not quite sure I understood. So here's someone said that about a year ago, she had her first series of visual aura. I always do this with the aura, interfering my vision in both eyes, even with eyes closed, even without headache, that went away on its own in less than 20 minutes. So she saw an ophthalmologist, and the ophthalmologist didn't think there was anything going on with the eyes. In something like that, would you also recommend that this person see a neurologist?
Yes, I would go further than that. I think if you can think about it, because, like, it's like if your vision changes, it's hard to think because it's scary, there's all
Yeah.
this thing happening. But if you think about it, it's really important information to close one eye and look at what you see, and close the other eye and look at what you see, because that information helps healthcare professional know, is it coming from one eye or is it coming from the two eyes? Because if it's coming from the two eyes, it's likely coming from the brain, so it's likely migraine visual aura. So
Mhm.
yeah, they would be a neurologist, not an
Yeah.
ophthalmologist.
And I think it doesn't mean that like anything scary is wrong or you have a brain tumor or whatever, but if you're starting to have aura, you might want to check it out. It may or may not be aura. Okay.
Yeah, and you may get treatment so they get better because it's annoying to
Right.
have aura. Yeah.
It's very scary the first time, and then after a while you kind of owe that again. Wendy asked a great question. She said, "So who diagnoses headaches?" She said, "Primary care, neurologist, ENT, ophthalmologist." She said, "All these specialties could be seen because of headache."
Yeah, that's in a perfect world, right? Everybody would diagnose headache. It depends on the comforts. I've seen wonderful headache diagnosis by primary care ENT and ophthalmologists, and I've seen some who refer to me because they have no clue and they want someone to check it out. So anyone, technically uh, pre-can diagnose headache. I think it's good to talk about it first with your primary care, and then if they don't know, get referred by. I think it's sometimes I work a lot with ENT because oftentimes there's different headache disorder that kind of look like ENT and they end up at the ENT, but then it goes to neurologist. Part of the issue sometimes, at least where I live, it's easier to see an ENT than a neurologist. So people go to ENT first. But I would go headache, I would go primary care, and if that's not enough, neurology.
Yeah. And to take it seriously and to see someone else if you feel that this really is concerning you and it's not getting better. Great question here. Is there a correlation between stress and headaches?
Oh, yes,
Yeah,
you probably know because you're asking.
yes.
Yeah, and it's mediated by the same brain areas too, right? Things feeding on each other. And sometimes it's tricky, and I think that's even more annoying, but that's my own bias. The let down headache or let down migraine, people push through and through stressful situations, so the cortisol and all the stress hormone rise. So that protects them from pain. And then when everything calms down, they get hit by this horrible headache. So we also see let down headaches.
And I want to make sure I understand what you're saying. Lead on headache.
Let down, like when the,
Oh, let down headaches.
yeah,
Oh,
yeah.
yes. So
So
people have a big presentation, something, or you talked about vacation. They work so hard to go on a trip, and then they're supposed to be relaxing and they have a headache, and people say, "What's wrong with you? You're on vacation." But it's because of that other period. Yeah,
exactly. So that's very common, and that's not immediately, visible that it's from stress too, but that's
yeah. And
another
I
thing.
think, again, some of this is because we've talked many times before today, but let's stop blaming ourselves. Like some of this we can control, we can't control everything. So, yeah.
Yeah, exactly.
Wendy asked a great question here about degenerative discs in the neck, and you'd kind of alluded to that. And so, what she's found is she's mixed up analgesics like Excedrin, Aleve, Tylenol. It seems to help, but is that safer than taking the same kind of medication all the time?
Yeah, that's another thing that oftentimes worries me much more than people talk about medication overuse headaches. And I don't know exactly, the frequency and the dose, but when I see people use a lot of analgesics, I'm not worried about medication overuse headache. I'm worried about the kidneys, the liver, the heart. So, yeah, it's not a bad idea. I think when possible, we try to do neuropathic pain medication, neck physical therapy, in like deeper injection with pain management if possible. Like we try different approaches to try to decrease the need for this analgesics. And that's not so much from, at least to me, a medication overuse. It's more chronic use of this medication in and out itself. Yeah,
Yeah. Yeah. I am sorry for anybody who has that pain though. I really am. I don't have that, but yeah.
it's very
Um,
common.
this is a great question. Can food intolerances and sensitivities cause migraines in kids? If so, do you recommend doing a food sensitivity test?
Yeah, and that can, I mean, different, right? So migraine is a genetic neurological disease. So food sensitivity would not cause migraine. But we see different conditions that may be more common in migraine, or people have migraine and this other condition, and it makes migraine worse. But if you have noticed something, yes, kids, I see it in adults all the time. I guess that's been missed for a very long time. But talking with allergist, immunologist, oftentimes what we see too in the migraine world is histamine sensitivities tend to be one of the common one. Also gluten, and people can have gluten sensitivity without having celiac. So yes, I think it's a good idea to get it checked
And
out.
if I understand it, so it's not necessarily that these sensitivities cause migraine, but they could cause headache. Is that correct?
Yes,
Okay.
exactly. Yeah.
Okay. So that's good. This is a great question. What if you just get aura with no headache? Is that okay? Mm,
I mean, I cannot make a value judgment, but yes,
right.
it's a diagnosis. It's more, and oftentimes we see that more commonly too as a age. So yeah, that's very common. And I've seen people too never had that family history, but never had any headaches, and they develop aura without headache around the later 50s, 60s. We see that quite
So if
often.
you have aura and no headache, still check it out. Is that what you're saying?
Yes, and it's a diagnosis.
Yeah,
Yeah.
yeah. You were talking about how headaches change as we age. I always used to have the classic aura headache. Now I get the aura, no headache. They come separately, and but it's still a diagnosis. It's still migraine.
Yeah, and it's very, that's very common. That's a common change.
Um, Can you talk? And I think this is the same question, or the having the aura with migraine with no headache. It's part of, if I understand you correctly, it's part of the disease, and they just don't necessarily happen at the same time.
No, and we still don't know. So, all right, cortical spreading depression. You have this wave of neuron excitability going from the back of your head to the front. And it's still in the hypothesis world exactly like how does that mechanism relates to the pain of headache, but they don't necessarily go hand in hand.
Yeah. All right. So Joan, thank you, Joan, is has been picking up some of the questions. So we have about 4 minutes left. I'm going to try to cover as many as we can. Um, Real quickly, Abby asked, how about caffeine and diet? Does too much caffeine cause headaches? Does not enough caffeine cause headaches? What's your thought there?
Uh, yeah, it's a tough question, and I think not all of the headache specialists agree in it. Some headache specialists will tell the patients like stop caffeine altogether, like caffeine withdrawal headache. I think most of us are okay with 1 to 2 cups of caffeine per day. For a lot of people, caffeine provides relief, if anything. I've seen people do best when they take caffeine in the morning and at regular times too. Because sometimes what's tricky is a change of schedule. Like people wake up at 6 and take the caffeine at 6 every day, and then Saturdays they wake up at 8:39 and take caffeine later, and then they get, I mean, pretty different factors, but it helps to keep it at a regular time. Diet, there's a lot of talk out there about migraine and diet. I think migraine is a disease that is so limiting in so many ways. I don't have it in me to limit people's diet too much based on not great evidence. The evidence we have is for the proportion of omega-3 and omega-6, so that we know. So limiting processed foods as much as possible, that I talk about. Regular food intake, trying anything with slow sugar, slow carbs to try to maintain a constant blood sugar and don't get yourself hungry. But I don't tell people, and food triggers are so hard to pinpoint. So unless there's a specific food sensitivity, a healthy plate, diet, regular,
Yeah.
limiting
All,
processed
all the
food.
things that we talk about in Wellness Wednesdays. I think we have time for a couple of more, and these are really good ones. So, in addition to physical therapy for the neck, does massage help headaches? Does massage help migraine?
Yeah, it's a tricky one because I think it's also depend on the person. What else? Migraine can cause neck pain and neck muscle tension in and out itself, but there may be other things going on. The neck is very sensitive part of the body with many important structures. So some people say it helps and find great benefit, but it can go both ways too. So as long as you keep it gentle and you make sure the massage therapist follow what feels right for you to not make things worse too.
And is that the same for acupuncture? Does it help some people, maybe not everyone? Can it help with headache
Yeah,
and migraine?
The same thing, acupuncture can help also with migraine, everything, and we cannot predict who will respond best to what, acupuncture, and in terms of medication too. But some people can find relief from acupuncture too.
And if you, let's say you suffer from headaches, you can see a neurologist. You can see a neurologist like you who is also a headache specialist. How important is it to see a neurologist who's also a headache specialist?
I mean, when you look at guidelines, they say that most people headaches can be managed by primary care, and then the small percentage that needs neurology and small percentage that need headache specialist. So, and it makes sense because there's not enough headache specialists. But the problem with that, if you're not picking up stuff that may be worsening the whole system, once you reach chronification, worsening of the migraine, it's really hard to go back. So I think it's trying primary care if you feel like things are not moving in the right direction, escalating, advocating for yourself, escalating to not get stuck, because undertreated migraine and a headache disorder is a risk for worsened pain and worsened disability.
Yeah. And I'm just going to add to that because I see where a time is like be the squeaky wheel. I know there's a long wait for a lot of these positions. What I've personally found is if you're nice and you call and you are persistent, your physicians will get you in. Dr. Olivia, I wondered if we would have enough to talk about today. Oh my gosh. Thank you. Dr. Olivia has spent a lot of time with me getting ready for today, and we have wonderful materials to send you. In your handout, it also includes how to find a physician, how to find a specialist, how to use virtual neural health care if you don't have access to a specialist. So we have lots and lots of options. Thank you so much, Dr. Olivia. We wish you the best. And for anyone in Stamford, Connecticut, you could come visit.
Yes, happy to see you, and thank you so much for having me. Thank you all for your great questions. And Sally, if you want to, if there's questions that are unanswered and you want me to draft little answers to send, I'm also happy to. I'm sorry we didn't get to everybody's questions.
I will do that. Thank you very, very much. All right.
Thank
Have a
you.
great day, everyone.
Thank you.
Big thanks.
Bye.